Thank you, Prince. So we proceed now to today's session, and I'll introduce today's speaker. So today's speaker needs no introduction. He is a word-renowned geopathologist and an authority in prostate pathology. Please welcome Dr. Rajal Shah. Dr. Shah is a professor of pathology at University of Texas. Dr. Shah has huge experience in prostate pathology. He has had numerous leadership positions in both academia and industry. He is an active member of GURPS and also has served as past president of Genito-Uropathology Society. Dr. Shah has more than 170 publications with more than 27,000 citations and H-index of 72, and has published numerous book chapters, has written two books on prostate pathology. He also runs a very popular YouTube channel, educational YouTube channel on urological pathology. I don't think we can have a better person to enlighten us about prostate, especially the large gland lesions. So without much ado, I request Dr. Shah to take over and start and teach us with his wisdom.
Thank you, Seema, for that very kind introduction. Good morning, good afternoon, or good evening, depending on which part of the world you are joining from. So I think first I wanted to remember Sambit. I came to know Sambit during perhaps last 2 to 3 years more closely. I think during my stint, I find him extremely talented, passionate educator, and most importantly, a very kind human being. These are some of the memories that I captured, have been able to capture along with him. In January of 2024, he invited me to Core Diagnostics in New Delhi. You can also see Seema and Anandi in the audience. We invited him for GUPS IAP conference in Cancun, Mexico. So these are some of the moments there. And I think more importantly, for last year, I was working very closely with him for the first of a kind International Cancer Congress in Urologic Oncology and Urologic Pathology in Bhubaneswar, which was held in January of this year in collaboration with GUPS and several local chapters. And I can say that I think that meeting would have not been successful or not been possible, I would say, without Sambit. So huge kind of contribution that he provided in that successful meeting. And just after 3 days of that successful meeting, I heard this incomprehensible news of his passing away. But Sambit will always remain in our hearts. So I first want to thank both Anandi and Dr. Bishan Sanjay Bedi for initiating this series. It's really one very important way we can remember the life, legacies, and work of Sambit, and Sambit will always remain in our hearts. So with that somber note, I also wanted to let you know that I think we posted, I think in the GUPath Society website, Sambit's obituary, which is beautifully written by close friends and colleagues. So if you have not read it, I think please I encourage you to read it. So switching to my topic, I mean, one common architectural pattern that we all are very familiar with is small acinar or small glandular pattern, as shown here in this example of grade group 1 prostate cancer. But infrequently, prostatic lesions may demonstrate predominantly a large gland morphology. The topic of my presentation, I will specifically focus on the atypical large gland proliferations. So large gland lesions of the prostate are defined by 3 criteria: prostate gland proliferations that are of the same size or larger than benign glands. They can exhibit tufted, micropapillary, flat, papillary, or cribriform architecture, and they may represent an intraductal or invasive process. Most of the time, in my experience, majority of these proliferations, if you end up staining with basal cells, you will see some basal cells. So they largely represent intraductal spectrum of lesions. The histological spectrum is pretty broad and includes pre-malignant, suspicious, and malignant lesions, often biologically aggressive entities such as intraductal carcinoma and ductal adenocarcinoma. So I think this particular spectrum, in my experience, are diagnostically often challenging and you need to have a careful morphological and sometimes immunohistochemistry and molecular approach to correctly diagnose these lesions. And when you deal with these lesions, always consider central zone gland and clear cell cribriform hyperplasia as important benign mimics before you make a diagnosis of these entities, because they can often mimic some of these lesions. As seen here, each entity has a unique bioclinical significance and management implications. So in this particular differentiation, of course, the differentiation of high-grade peen from other mimics is especially important. So I will first focus on high-grade peen. High-grade peen is defined as an architecturally normal glands as seen here in this low power, but cytologically malignant appearing secretory cells. And basal cells should be always at least focally preserved. It has a higher incidence in blacks compared to Caucasians. It can only be diagnosed by histology. So that's a very important fact to know. No specific clinical or radiological findings, and it does not elevate PSA. Presence of distinct prominent nucleoli in secretory cells visible at 20x magnification is the best morphological discriminator for diagnosis of high-grade peen and differentiating it from other mimics. Infrequently, mitosis and hyperchromasia can be a primary morphological manifestations for high-grade peen diagnosis, but these days we always want to have a higher threshold to make the diagnosis of this particular lesion, and we will talk more about that. Due to its poor inter-observer reproducibility and lack of cancer risk in subsequent biopsy, the diagnosis of low-grade peen no longer should be made neither in the report, neither we really want to use that term anymore. And this latest WHO edition also does not recommend you to use the term. So very important point, no more low-grade peen. High-grade peen has three major architectural patterns: tufting, micropapillary, and flat. Tufting is the most common pattern. The lesions that you may think represent cribriform high-grade peen, recent studies have shown that they are clinically very significant lesions. You cannot exclude underlying intraductal carcinoma. So the diagnosis of cribriform high-grade peen, at least in biopsy, should not be made. This is another very important concept to keep in mind. When you deal with this type of so-called cribriform high-grade peen lesions, it is the better to use them with the term atypical intraductal proliferation suspicious for intraductal carcinoma, and I will talk more about that. These are two very infrequent manifestations of high-grade peen, rarely nuclei, atypical secretory cells may be polarized towards the luminal aspect, giving it a more inverted appearance, and sometimes you may deal with a foamy high-grade peen. High-grade peen has two important significance. In the short term, within 12 months, it could be a marker of concomitant but missed cancer in initial biopsy, and long term, it is considered a precursor lesion to prostate cancer. In contemporary biopsy practice, which is typically defined as 8 or more course sampling, you can see that the significance of high-grade peen as a marker of missed cancer has significantly reduced. It is no more significantly different than a benign diagnosis in compared to the course which were less than 8 in traditional biopsy practices. So high-grade peen diagnosis on extended biopsy is not associated with significantly increased risk of missed cancer anymore, as long as you have an extended biopsy and does not need repeat biopsy within the 1 year of the diagnosis. However, in 3 settings, high-grade peen still could be a significant marker of missed cancer when you are dealing with multifocal high-grade peen defined as a 2 or more course involvement, peen with adjacent small atypical glands, and ERG overexpression in high-grade peen. So in these 3 settings, repeat biopsy may be still meaningful if there is particularly MRI abnormality. So the NCCN pretty much recommend a conservative follow-up or conservative manage for patients with high-grade peen diagnosis with regular follow-up, PSA, and digital examination at 6 to 24 months intervals. Only in some of these high-risk situations, which I mentioned, that improve the specificity of screening, you may want to also add multimetric MRI, and if there is MRI lesion, then repeat biopsy is clearly needed, and patient should undergo repeat biopsy in this setting. So in summary, the predictive value of high-grade peen as a marker of missed cancer has declined significantly in recent years. Therefore, we must use stringent diagnostic criteria, keep a higher threshold, be conservative in the diagnosis when high-grade peen is the only diagnosis in biopsy, and report the number of course involved by high-grade peen, because as I've shown you, that is still a meaningful indicator for the risk of missed cancer. So let us review some cases. This is a case from 56-year-old male who presented with rising PSA and doubling time. His pre-biopsy PSA was 17.79 nanogram per ml and had a Pirates 5 lesion measuring 25 millimeters, so pretty big lesion. He also had a lung, liver, and bone lesions, and he underwent lesion biopsy. So this is the lesion biopsy, and you can see that there is a pretty big duct-like space where you see this complex papillary and somewhat cribriforming appearing growth. It appears pretty blue because there is a lot of nuclear pseudostratification. So the lining epithelium has a columnar look due to this elongated nuclei. Almost it looks like a thick wall of epithelium. And you can see the papillary architecture here characterized by fibrovascular cores. So here are some of the differential diagnoses, and you will agree that in this setting with this papillary architecture and location within the urethra, you really want to rule out a high-grade urothelial carcinoma in your differential diagnosis. So I did some markers. The tumor was NKX 3.1 positive, but negative for GATA3, and PIN4 demonstrated lack of basal cell staining and overexpression of AMSCR, which I have not shown here. So the diagnosis of this case is ductal adenocarcinoma, Gleason score 4 + 4 = sign 8. And ductal adenocarcinoma represents a distinct subtype of prostate adenocarcinoma. It accounts for less than 1% in pure form and 5% in the mixed ductal acinar form. It may present centrally as a urethral polyp, typically when it is more pure in presentation, or peripherally in needle biopsy, often with a component of acinar adenocarcinoma. So mixed presentation is more common when they are detected in needle biopsy. It typically presents with advanced stage and aggressive disease with a propensity to metastasize to the visceral sites. You know that prostate cancer really likes to go to the bones, but in this particular entity or this particular type of prostate cancer, visceral sites of metastasis is much more common. And it also is known to metastasize to rare body sites like listed here. It is graded as a grade 4 or 5 when a solid component or necrosis is present. So histologically, you will typically see cribriform or papillary architecture. Usually a combination of both is very common. Sometimes you may have a predominant papillary or predominant cribriform architecture. Rarely you may see focal solid or peen-like growth pattern, which we will talk more about this, but you can see here these glands have a pretty flat architecture. There is no papillary growth. There is no complex cribriforming architecture, but beautiful ductal epithelial features. So the central theme is glands are lined by tall columnar cells displaying elongated atypical nuclei and nuclear pseudostratification. So very important point to keep in mind. Again, you want to keep a higher threshold for this diagnosis. Just don't use, because at low power, those papillary type of components often mimic like ductal adenocarcinoma, but when you look at high power, they have a beautiful rounded acinar type of nuclei. That is not something I would allow for the diagnosis of ductal adenocarcinoma. So here is one beautiful example from radical prostatectomy, beautiful papillary morphology, cribriform morphology, and again look at very thick wall-like glandular lining epithelium because of that nuclear pseudostratification and elongated columnar lining epithelium. So very important to keep that morphological feature in mind. Also, ductal adenocarcinoma commonly grows in pre-existing ducts and spaces. So if you do basal cell marker, you will commonly see intraductal spread in this type of prostate cancer. But there has been a lot of confusion between ductal and intraductal cancer, but keep in mind that they are not the same entity. Even though ductal adenocarcinoma can have intraductal component, they are not the same thing. Ductal carcinoma, we are referring to a separate type of prostate adenocarcinoma. It is the morphological or cytological feature of the cancer, while intraductal represents the growth pattern of adenocarcinoma, not a separate type or variant of prostate, and it refers to location within the ducts. It can be both commonly acinar type or rarely can be ductal type. So very important to remember. This is a very important study that we recently published. We revisited the ductal adenocarcinoma and interrogated its clinical, pathological, and molecular features, and identified a significant heterogeneity within this spectrum of diseases with important management and clinical implications. And as you can see here, Sambit is an important part of the co-author and collaborator of the study. So what did we find? I think we find three types of ductal adenocarcinoma presentation. Ductal adenocarcinoma involving both central and peripheral prostate in our experience, where the prototypical form of ductal adenocarcinoma, which classically are associated with aggressive outcomes, low PSA, high volume, extraprostatic disease, and visceral metastasis. They typically present pure or predominantly ductal, pure ductal in nature. They are enriched in DNA repair gene defects. So particularly BRCA mutations, ATM alterations, these are much more common. They also frequently have germline DNA repair gene defects. And also mutations in P13K pathway alterations were frequently seen. So this particular group of disease, when you identify that treatment should be more multimodality treatment approach, because they often present outside prostate and they are already have spreaded outside the prostate. And these patients may benefit from PARP inhibition, which is a very important molecular target for this type of tumors. Tumors involving peripheral prostate only were associated typically with acinar adenocarcinoma, so they were mixed in presentation. Both ductal and acinar components are likely are clonal. They were enriched in FOXA1 alterations, but not DNA repair gene defects. So we believe they are potentially transformation from acinar adenocarcinoma. And then we had a small spectrum, 2 cases with central only involvement, just involving only urethra. So they're classically presented as a urethral polyp and were diagnosed based on TURP or urethral biopsy. They had excellent outcomes on follow-up radical prostatectomy. No residual ductal adenocarcinoma was present in both cases. So they likely represent an in situ form of disease. So understanding this clinical heterogeneity and appropriately working up when you deal with this ductal adenocarcinoma, as you can see, has an important clinical and management implications. So next case is a 60-year-old man presented with rising PSA. The latest PSA is 3.97 nanogram per ml, 6 millimeter Pyrite score 4 lesion. And here are some of the other findings that you may find in an MRI report. Pay attention to that, but don't get biased with that necessarily. Our job is to still make sure we independently interpret without getting significantly influenced by MRI findings, particularly for those patients who are on active surveillance and undergoing repeat biopsies. So here is the biopsy from the lesion, and as you can see here is made up of significant proliferation of large glands with predominantly flat, tufted, and little bit micropapillary type of occasional proliferation is seen. At the periphery, you also see some small acinar atypical proliferation. At closer examination, you can see that there is a significant stratification, and you can also appreciate the infiltrative nature by this. I always tell my residents that when you interpret, when you evaluate prostate specimens, always try to find some normal benign glands and try to compare your lesion with the benign glands, and you will find important differences which should be present when you are classifying a lesion as a cancer. And as you can see here, there is a nice comparison between benign versus this more malignant appearing glands in terms of cytology. You can also appreciate the infiltrative nature when you see the proliferation all around these benign glands. So we know that this is also infiltrative in nature. Another thing is that these nuclei appear much rounder, like basically this looks like acinar adenocarcinoma nuclei. I mean, there may be occasional elongated nuclei, but these predominantly nuclei are rounded, acinar-like. So that's an important morphological feature to appreciate. Again, here you can appreciate that much better. Here you can see that this small acinar proliferation, which appears to be more conventional nature, is also appreciated at the edge of the biopsy. And here are some of the differential diagnoses. And in the setting like this, when you have a predominantly high-grade peen-like proliferation, your critical differential diagnosis is, of course, high-grade peen. Ductal adenocarcinoma would also be important to make sure that you don't miss it. And then, of course, peen-like adenocarcinoma. So in this setting, you must have a high index of suspicion here, particularly the presence of glandular crowding and the presence of conventional acinar differentiation are important reminders for you to consider that this might be peen-like acinar peen-like adenocarcinoma. And you can see that peen-4 stain shows beautiful normal basal stained benign glands, and then cancer focus has pretty much a loss of basal cells with strong overexpression of AMACR. So the diagnosis for this is peen-like adenocarcinoma, Gleason score 3+3=6, and we will talk more about this now. So peen-like prostate adenocarcinoma are defined by proliferation of several simple. Very important to understand that these are simple gland proliferation. They should not have a cribriform or papillary architecture. If you see cribriform or papillary architecture, that would disqualify them from this diagnosis. There should be stratified malignant epithelium and lack of basal cells. And we saw all these criteria meeting in our case. Peen-like adenocarcinoma is a rare subtype of acinar adenocarcinoma resembling high-grade peen. Its incidence is about 1% in prostate biopsies. It is often mixed with, and the clinical presentation is no different than usual acinar adenocarcinoma, and it can rarely present in a pure form. So this entity was first described by Dr. Hamid and Humphrey sometime in 2006. They studied 8 cases in needle biopsies. 4 were pure peen-like and 4 were mixed with acinar and peen-like. And interestingly, they observed 2 types of morphological spectrum. One is non-columnar cells with rounded nuclei, similar to ordinary acinar adenocarcinoma, like the case that I showed you. And the other was columnar cells with elongated nuclei, similar to ductal adenocarcinoma epithelium. So here is this side-by-side comparison. You can see that this is more like ours, peen-like adenocarcinoma showing rounded acinar type nuclear features, while here is your wall, thick wall type of epithelium with a stratified elongated nuclei. So this is more peen-like ductal epithelial features. So these particular peen-like ductal epithelial features were later on coined the term high-grade peen-like ductal adenocarcinoma of the prostate by Tavora and Epstein. They had something like 28 cases in their series, and they reported the biological behavior is similar to Gleason score 3+3=6 in contrast to Gleason score 4+4=8 for traditional ductal adenocarcinoma. So the distinction is obviously very important. So a caveat and a potential pitfall that I want to warn you when you deal with this type of situation. This is a radical prostatectomy, and you can see here that many glands have a beautiful peen-like morphology, right? Simple glands, no papillary architecture, no cribriform architecture, and beautiful ductal epithelial features. But when you see them more closely, you can start seeing some cribriforming proliferation. Here also you start seeing some papillary architecture, but look at this beautiful ductal epithelial features. This is what you really want to see, at least focally prominent in a particular lesion that you classify as a ductal adenocarcinoma. So I think keep in mind that ductal adenocarcinoma can have a component resembling pin-like ductal adenoepithelial features. So this is an important pitfall, and that's why I don't like to make a diagnosis of pin-like adenocarcinoma when showing ductal epithelial features in a needle biopsy, because I cannot completely exclude the possibility of ductal adenocarcinoma. And I mean, summarizing, limited data show that the pure pin-like adenocarcinoma is exhibiting conventional epithelial and ductal epithelial features as behavior similar to Gleason pattern 3 adenocarcinoma compared to traditional ductal adenocarcinoma, which has a much higher significance. So in WHO 5th edition, the term pin-like ductal adenocarcinoma was replaced with pin-like adenocarcinoma, just simply pin-like adenocarcinoma, because ductal adenocarcinoma connotes a more aggressive behavior. And I think this is a good replacement, but at the same time, they did not provide any clarifications regarding these two potential morphological spectrum of pin-like adenocarcinoma and how to deal with them. So I think this is still a little controversial area, and I think we need more, studies highlighting some of these type of cases, and I think that's hopefully we can nail them down more, in future. The third case is a 78-year-old man presented with rising PSA. Latest PSA is 64.2 nanogram per ml. Prior inconclusive biopsy and pyrex was 5. And patient also had indeterminate left iliac bone lesion. So the presentation here is pretty aggressive looking prostate cancer. And when I got the biopsy, I saw this spectrum of this kind of large glands and duct-like proliferations with variety of atypical epithelial kind of spectrum. Some areas it looked more dense, some area it looked little more loose cribriforming or little papillary looking. And I think you can see in some areas there is a marked cytological atypia. Some of the nuclei are way too bigger than some of this comparison to adjacent nuclei in comparison, particularly to benign glands. So here you can see again this comparison with the benign glands. So one thing that you have to make it very clear that when you deal with this type of proliferation, ask your questions that do you have a definite invasive carcinoma in the case, invasive non-cribriforming carcinoma? That is the most important. Do you have definite non-invasive cribriform carcinoma? And the answer is no. Then you must do the basal cell markers to prove that this is an intraductal process and not invasive process. But again, I think seen here this beautiful cytological atypia, which we will talk more about that. So this atypia, you will agree that it is way too beyond than anybody would allow in a high-grade pin, or even it is little bit beyond for atypical intraductal proliferation, suspicious for intraductal carcinoma. This is almost reaching the level to classify this as a intraductal carcinoma. Here is more example, and here are some more. And again, see this nuclear atypia. These are very enlarged, almost what you would define as a bizarre type of nuclei in some of these proliferations. Here is more, and I think you can actually see the basal cells lining very clearly in this particular glandular proliferation. So morphologically, another thing that you can appreciate very well is that these glands have a branching contour. When I see that, I always find it that that's more likely to be an intraductal process rather than invasive process. But I don't see any definite invasive cancer, so I need to do basal cell stain. Here is the PIN4 stain, and you can see that Each gland is nicely decorated by basal cells with some AMSCR overexpression in those atypical proliferations. Here is another level. So here are some of the choice, and I think again, as I told you, high-grade pain is big no-no. So don't even consider when you have this degree of proliferation, atypical glandular proliferation, and this degree of cytological atypia. And we did not see any definite invasive cancer with basal cell markers all around. This is intraductal carcinoma of the prostate. Now, it is true that this process has a range of proliferation. So some of these proliferation would qualify for intraductal proliferation. But as I will talk to you just next, that atypical intraductal proliferation is essentially a morphological spectrum of intraductal carcinoma. And that's an important concept to understand. So I think with the clinical presentation that we have with a very high PSA, Pyrex 5 lesion, patients like this could be definitely treated without really undergoing a repeat biopsy. And this patient underwent radiation and androgen deprivation therapy and also had subsequently bone metastasis. So we will talk more about this. So intraductal carcinoma of the prostate has two morphological hallmarks. Number one is expansile proliferation of cancer cells in a cribriform or solid architecture, and proliferation is within native prostate gland. So basal cell layer is at least partially preserved. We have made excellent progress in understanding intraductal carcinoma, but there are many still controversial issues that remain. Particularly, there was a contradictory grading recommendation regarding the intraductal carcinoma. As you might be aware, that in 2019, the two societies, even though they meant that intraductal carcinoma is clearly an aggressive histological feature, but they gave somewhat different grading recommendations, which has created significant confusion amongst both clinicians as well as surgical pathologists. So as a GUPS president, along with my counterpart, Dr. Glenn Christensen from ISUP, we convened and decided to do an expert consultation conference on intraductal carcinoma of the prostate. Our major objectives were to clarify unresolved issues regarding IDCP and AIP terminology, diagnostic criteria, grading and its management implications. And most importantly, we wanted to develop uniform reporting and grading guidelines for IDCP and AIP, which is endorsed by both societies. So we really wanted to put this controversy behind, and I will show you that I think overall we had a great success with this intraductal consultation. We invited a total 32-member expert panel. 5 were core members, including 2 of us as a president, 25 other panel pathologists and 2 urologists. We utilize a modified Delphi approach with multiple rounds of consultations and voting, supplemented by discussions at the Boston USCAP meeting, which was attended by over 212 participants. An expert consensus was defined as 2/3 of the panel members or experts agreeing to a particular statement, and greater than 90% agreement was defined as a strong consensus. So I will show you some of the important findings, and this is very first time I'm presenting these findings. So this is really a very exciting kind of time, I think, in this particular talk for me. So there was a strong consensus that updated GUO and Epstein criteria should be utilized for both biopsy and radical prostatectomy type of settings. As you know that these criteria were proposed by GUO and Epstein based on 27 cases of prostate biopsies with diagnosis of only IDCP. So the diagnostic criteria were designed to identify patients who should be treated with definitive therapy even in the absence of invasive cancer. Hence, the bar is very high. So if you follow these particular features, you will make the diagnosis, and that diagnosis would have a high specificity but low sensitivity. You could miss a lot of intraductal carcinoma, but if these features are present, then you would be confident that patient could be treated without really having any issues. So these were the original criteria: solid intraductal, dense cribriform. When you have these two, you can make confident diagnosis. There was some confusion regarding the dense cribriform definition. And when you have a loose cribriform or micropapillary intraductal proliferation, you require either mark atypia, defined as a 6-time enlarged nucleus compared to adjacent normal nuclei, and or non-focal comedonecrosis. So modified this particular panel pretty much adopted the 2019 GUPS white paper recommendation. The dense cribriform is now defined as a more cells than the luminal species. So basically, essentially greater than 50% cellular mass than the luminal species. And you don't require 6-time nuclear enlargement criteria because of its subjective and rather arbitrary nature. It is replaced by mark, which is defined as a bizarre or pleomorphic. This word is somewhat important because mark itself could be also somewhat less reproducible. But when we use word bizarre, pleomorphic, that would perhaps, I think, would be much more reproducible, and then or non-focal comedonecrosis. So essentially same criteria with a more refined definition for this criteria. So here is a beautiful example of dense cribriform, more cells than the luminal species. Intraductal carcinoma can also sometimes present with only solid architecture, and in this type of setting, you should exclude high-grade urothelial carcinoma from your differential, very important. Intraductal carcinoma also has a strong propensity for intraductal spread. So if you do basal cells, you frequently find the basal cells around these ducts. And now again, I will talk about that, but this type of morphology you will grade essentially as a grade 5. And when you have only cribriform, you would grade as a grade 4. Very rarely you can have a non-expansile lesion, but mark or bizarre cytological atypia. You can see that you clearly have a beautiful basal cells. So these likely represent a pagetoid spreading of prostate adjacent high-grade prostatic adenocarcinoma. It is important again to rule out radiation atypia and spreading of high-grade urothelial carcinoma before you make this diagnosis. But this is one rare setting that Go and Epstein criteria, even though are not there, you can still make a diagnosis of intraductal carcinoma, and there was a strong consensus for this particular definitional feature. And now I will show you that intraductal carcinoma in general can commonly mimic with invasive cribriform cancer. So I think many times you may require basal cells to correctly separate between the two, but certain morphological features when present can help to distinguish an intraductal process from invasive cancer. So when you see branching glands with rounded contour, that I find very, very helpful. Beautiful example here. Because this is like kind of spreading in a pre-existing glands. That's why they are going to have a branching undulated type of borders and lumina. The partial involvement of native benign glands can be also very helpful feature. And when you have these type of feature, you technically really do not need basal cells to prove that it is intraductal versus invasive process. Two-cell population with outer pleomorphic and inner smaller nuclear cells is also very, very helpful feature. So now let's talk about intraductal proliferative lesions. So we saw an example of high-grade PIN. We also talked about intraductal carcinoma. So high-grade PIN is what we will define as architecturally least complex, architecturally and cytologically least complex process, while intraductal carcinoma represents architecturally and cytologically the most complex process. So this is a morphological continuum. So even though molecular studies have shown that high-grade PIN and intraductal carcinoma are clonally different, they are not clonally related. There is going to be somewhat overlap in interpretation between these two spectrum, and there is going to be a spectrum within this, in between two, which may be more difficult to diagnose as either of those two, which has been referred to as an atypical intraductal proliferation or atypical cribriform lesion. atypical intraductal cribriform proliferation, atypical intraductal proliferation, suspicious for intraductal carcinoma. Here is one such example. They typically present with loose cribriform architecture, lacking severe nuclear atypia or comedonecrosis. So these type of lesions in past have been also diagnosed as a cribriform high-grade pain. But as I told you that diagnosis, we really don't want to make it because a lot of this, which I will show you, here is another beautiful example of atypical intraductal proliferation, which is suspicious for intraductal carcinoma. Why suspicious? Because they look clearly beyond high-grade PIN diagnosis, but they do not meet the full diagnostic criteria for intraductal carcinoma. They don't have that bizarre atypia, necrosis. They don't have a dense cribriform architecture or solid architecture. So I have studied quite a lot this type of lesions, and we showed that molecularly ERG and PTEN, when you do in this spectra of these lesions, atypical intraductal proliferation appears to be clonally related to intraductal carcinoma and its associated invasive prostate cancer. So there was a high degree of concordance of these markers when you have a AIP, IDCP, and invasive within the same lesion with a very similar expression pattern, which is shown here in this diagram, in this figure. We also studied 62 cases with AIP only or AIP with grade group 1 or grade group 2 without any cribriform architecture, which could be potentially candidates for active surveillance. And what we found that AIP in biopsy is a marker of unsampled intraductal carcinoma, as well as other adverse pathological features which were defined as a grade group 3 or higher, extra prostatic extension, seminal vesicle invasion, and cribriform Gleason pattern 4 at repeat biopsy or radical prostatectomy. These are, of course, will be applying for, some of them would be applied for radical prostatectomy. Most of them had a radical prostatectomy follow-up. There were some with repeat biopsies as well, particularly for AIP alone type of setting. So based on this data, the diagnosis of AIP only and AIP with grade group 1 prostate cancer would require a repeat biopsy to rule out unsampled aggressive cancer. So before putting AIP with grade group 1 for active surveillance, ideally you want to have repeat biopsy to rule out unsampled intraductal carcinoma or more adverse pathological parameters. Coming back to this intraductal consultation, as diagnosis of AIP may require repeat biopsy, the diagnosis of AIP should be made only in proliferations in which IDCP is favored. So the point is that you don't want to make the diagnosis of AIP very loosely. You still want to have somewhat higher threshold to make this diagnosis. So you use this term specifically in the setting when proliferations are suspicious for IDCP, but the criteria for that diagnosis are not met, which had a strong consensus for 90%. And I think the better term would be AIP suspicious for IDCP rather than AIP alone, as it is better indicates what we are dealing with. There is less ambiguity. That was also had a consensus. Diagnosis of cribriform high-grade PIN should not be made in a biopsy. Again, coming back to my earlier statement, and such lesions should be reported as AIP suspicious for intraductal carcinoma. This one had a total consensus. 100% of participants have agreed. Experts agreed on that. I also showed you that as PTEN and ERG are a very helpful marker in the setting of AIP and intraductal carcinoma, they may help in the distinction when high-grade PIN is in the differential diagnosis, but they will not be helpful to distinguish between AIP versus IDCP. They will be helpful more when you have a somewhat lower spectrum proliferation and high-grade PIN is still in your differential diagnosis. So in this setting, if you have a PTEN loss or overexpression, that would suggest more AIP suspicious for intraductal carcinoma rather than high-grade PIN. Let's understand this very briefly. Intraductal carcinoma are potentially two distinct scenarios. pure or isolated IDCP not associated with invasive cancer component. This presentation is pretty rare, less than 0.3% of prostate biopsy, and very important to understand that on follow-up, most have unsampled aggressive invasive cancer. So even though this technically does exist, it is an extremely rare diagnosis, and ideally you require a radical prostatectomy to prove that truly it is a pure IDCP not associated with invasive cancer. In comparison, the second type, invasive type IDCP, is associated with invasive cancer, typically high grade and high volume prostate cancer. Rarely it can be seen only with grade group 1 cancer, but on follow-up, again, most of these grade group 1 prostate cancer have shown to have high grade and high volume cancer in radical prostatectomy or other adverse outcomes, even in the setting of grade group 1. So technically, you could argue that intraductal carcinoma are two distinct diseases. One could be like precursor type IDCP analogous to high-grade PIN. An example would be pure IDCP and IDCP associated with grade group 1 prostate cancer. But again, in this biopsy setting, you really don't know until you really have examined full radical prostatectomy. And the second type, which is a very common scenario, is essentially represents a growth pattern or colonization or vegetoid spreading of invasive prostate cancer. And there was a strong consensus that this is what the likely representation of intraductal carcinoma. So intraductal carcinoma is essentially a colonization or vegetoid spreading of adjacent invasive high-grade prostate cancer. Only very rarely situation it may represent a pure process. And I think that concept is very important to understand this grading controversy and how did we resolve this. I will not go further details into this, but this is an important concept for you to understand. So we know that in 2019, both societies issued grading recommendations. Both reported that GUPS should be IDCP should be reported, and it is an adverse histological feature. But GUPS recommended not to incorporate IDCP in the grading while when invasive cancer is present, while ISUP recommended to include IDCP component in grading when invasive cancer is present. When there is a pure not associated with invasive cancer at all, you do not grade IDCP. And that is a uniform recommendation. So the controversy applies only in the setting when you have an invasive cancer and IDCP component. So this third row indicates these recommendations from the expert panel. And again, we have the same recommendation in the setting of pure IDCP not associated with invasive PCA in biopsy or radical prostatectomy setting. In this setting, you do not want to grade IDCP and you want to use basal cell marker to prove the diagnosis. We also address IDCP spatially distinct from invasive prostate cancer. What I mean is that in the biopsy right side, there may be invasive cancer, but left side is only intraductal process. That could represent a separate process. So these were not issues was not addressed in the earlier this white paper and grading recommendations, but we addressed that, and there was a pretty good consensus that this should also not be graded as this form of IDCP should not be graded as well. So this both setting, when it is pure setting or when there is spatially distinct from invasive prostate cancer, you do not want to grade IDCP and you want to use basal cell markers to prove the diagnosis. But in the setting of IDCP with invasive prostate cancer, a major victory is that we have a uniform recommendation to include IDCP in the final Gleason score. Of course, the level of consensus was somewhat lower for grade group 1 setting, but we still achieved consensus. So you do not have to struggle anymore whether I should be including this in the grading or not. You can include the IDCP, and you must include, you can still report the IDCP, but you want to include the IDCP when associated with invasive cancer. So morphologically, as I talked to you, when you have a cribriform IDCP, you can count that as a GP4 or Gleason pattern 4. when you have a solid or comedonecrosis pattern, that would be graded as a Gleason pattern 5, and there was a uniform consensus for that. So these are my final take-home messages for clinical management, 4 entities that we talked about. High-grade pin-like carcinoma, ductal adenocarcinoma, and IDCP should always be considered in the differential diagnosis. Careful architectural and cytological details will provide you important clues for diagnosis. However, prudent use of basal cell markers is going to be necessary in some cases. P10 and ERG may be used in borderline atypical intraductal proliferation, where high-grade pin is potentially in the differential diagnosis. I talked to you about my study. We found this to be a heterogeneous disease, and understanding of it is critical to patient management. And big bonus for you guys was this recent IDCP expert consultation findings that I spoke. So I think at the end, I would leave with the kind of important point that effective communication with clinical colleagues is especially critical in this spectrum to avoid essential errors in patient management, because these are often confusing to clinicians, whether what is this I included in the grading, not included in the grading, intraductal versus ductal. All of this I have seen that clinicians are often confused with this. So I think you really need to have a good clinical dialogue with them when you are dealing with this spectrum. So with that note, I thank you for your attention. And again, I would like to thank both Dr. Sanjay Bedi and Anandi Lobo for inviting me to present in this series.
Thank you, Dr. Rajal. That was very comprehensive and lucid presentation, and I'm sure audience will benefit from your expert wisdom. And the bonus, of course, was the early bird's view of this IDCP expert consultation findings, which are very much needed, need of the hour. Thank you for sharing. So we have a couple of minutes left. I think we can take on a few questions. So we have a few questions in chat box. So there's a question from Dr. Michael. There are a couple of questions regarding AIP. So
मैं तकरीबन 2 मिनट में कॉल करता हूँ मेरा ना.
So Dr. Michael is asking, do we grade atypical intraductal proliferations? And
yeah, I did not cover that. AIP should not be included in the grading, and there was a strong consensus that AIP should not be graded in the final grade. Only IDCP.
All right. So another similar question, can it be likened to ADH in breast, and would it need a size criteria? And can we make a diagnosis of AIP on radical prostatectomies?
I think I personally think that the importance of AIP only diagnosis in radical prostatectomy is somewhat not that kind of important, I think. But within the CAP template, I think you can see that I think that that particular entity is included. So when I have that scenario, I still include AIP in my diagnosis. Now, during our consultation, there was pretty good discussion on whether I think we should have a different criteria for radical prostatectomy versus biopsy for intraductal carcinoma. But I think that would be more confusing to surgical pathologists, so we decided not to pursue that type of. But technically, if you see AIP in a radical prostatectomy, that to some extent it is a lower grade spectrum of intraductal carcinoma, as I shown you based on this data.
Right. Great. So Dr. Santosh Menon is asking, how do urologists react to the term AIP?
Well, that's a great question, I think. I mean, this is where I think that education is important for us. I think sometimes you have to talk to them what you are reporting and whether they are really understanding this or not. I think many urologists I have found there is still not understand what is AIP, but I think with this, what our initiative, which I showed you, those type of things, they are going to be in line with that. I mean, if they're not, I think then that's a problem, I think, for them, I think. But I think in certain situations, which I have shown you, try to call your clinical colleagues and explain them that this is what I think I'm dealing with, and based on the data, I think this is what I think would be the best course of action for these patients.
Right. So there's another question by Dr. Menon. Do you feel there's tendency to loosely call IDCP in the presence of invasive grade group 3, 4, 5 cancer?
I'm sorry, can you repeat? Sorry about that.
Do you feel there's a tendency to loosely call IDCP in presence of invasive grade group 3, 4, 5 cancer?
There is a tendency to loosely call.
Yeah.
Means just using lower threshold.
Yeah.
I think that's also a good point. I think in that setting, if you have a lesion pattern or grade group 3, 4, 5 type of situation, then technically presence of IDCP is not going to matter that much in the management decision, because it still will, management likely will not change. But I want to emphasize this one point, is that some studies have shown, which we have published, for a radio recurrent prostate cancer, they are often enriched in intraductal and cribriform morphology. Similarly, there are some studies which have shown that cribriform prostate cancers, which would include intraductal carcinoma, are often resistant to androgen deprivation therapy. So I think your clinical colleagues would still like to know that whether you are dealing with intraductal carcinoma. So I would not loosely apply. That is not something I would recommend. But I think the management implications would be somewhat less severe if you end up, I think, missing it or reporting it, I think.
Right, right. So we are almost over time. I'll quickly take one last question. So there's a question from Dr. Michael regarding molecular sequencing of prostatic carcinoma. Would you include adjacent foci of IDCP or AIP along with invasive foci? Would it be important for molecular treatment? This is the question.
I think that the answer is absolutely yes. I think this is clearly an aggressive histology, but I think that is why when your lab is called upon that there is a sequencing request, very important to identify the correct block for this type of testing, because if you end up giving a low grade Gleason 3+3 cancer and patient has an intraductal carcinoma somewhere else, then chances are that you are not going to have a molecular markers are similarly having a heterogeneity issues like the morphology. So I think that's a very important point to keep that in mind. Yes, absolutely.
Right. There are a few more questions.
But keep in mind that these sequencing methods are somewhat blind in nature. I don't think they use laser capture microscopy or those type of processes to correctly identify that whether you have this particular process is represented or not. That's why you want to give the highest tumor with the highest grade type of sample in your molecular testing.
Right. Great. So there are one or two more questions. If you allow me, I can quickly ask.
Yeah, sure.
Okay. So there's a question regarding, is there a prognostic value to mention the presence of IDCP in GG4-5 prostate cancer?
Yeah, I think that's what we talked about, right? Perhaps not prognostic, even though there could be predictive type of situations, because these patients are often going to be treated with androgen deprivation therapy or radiation, in addition to some other forms of therapy. Also keep in mind that intraductal carcinoma, they are often enriched with the DNA repair gene defect. So that is why I think sequencing is often done in these type of settings. So it has absolutely importance in selecting some of those multimodality treatment decisions, PARP inhibitions. They are looking for this type of targets. And now most of the medical oncologists are very familiar with this intraductal term. If you don't report it, I think, and if it is extensively there, I think they kind of perhaps will not like it, I think.
Right. All right. Thank you. Quickly, this is the last one. So Dr. Shivani is asking, at times it's very confusing to call a tiny focus in the core biopsy IDCP or a focus of small ductal adenocarcinoma. Any good pointers to be confident?
I'm sorry, let me repeat it. So I think, well, can you repeat it? Sorry.
So it's very confusing to call a tiny focus in, I think she means trus biopsy. So basically she wants to know what are the good pointers between IDCP and small focus of ductal adenocarcinoma in breast biopsy.
Okay, very good. Yeah, I think we talked about that. So keep in mind that the ductal adenocarcinoma can have intraductal spread, but if you are dealing with only intraductal component, then you have to pay attention to the morphological features. Are you dealing with a acinar type of intraductal process or ductal type of epithelial features? Those are the ones that are important when will help you correctly identifying. In my experience, most of the time intraductal carcinoma is going to be a manifestation of high-grade acinar carcinoma. While ductal adenocarcinoma sometimes can present like intraductal carcinoma, but only intraductal presentation is still relatively very rare.
Right, right. Great. I think we'll end here. So thank you very much, Dr. Rajal, for sharing all the pearls of wisdom. It's been very helpful and very insightful talk. And I think taking time and sharing your wisdom is a true legacy, true tribute to Sambit's legacy and our association with him. And also, thanks a lot for sharing all those insights from this expert consultation conference. We look forward to coming this in a print soon. And I'm sure, and I'm sure it will be much sought after paper, I'm sure. And I thank all the audience for joining us from various parts of the world at different time zones. And thank you, Dr. Anandi and Dr. Bedi, for giving me the opportunity to chair the session.
Thank you.
Thank you. Dr. Anandi, over to you.
Yeah, thank you. Thank you very much, Dr. Rajal Shah and Dr. Seema. Before we end, I just want to announce that our next lecture is coming up on the 6th of October, and it's by Dr. Khalil Al-Obedi from Michigan. He will be talking on papillary tumors of the kidney. So we have the link is in the chat box, and we will be circulating the flyer soon. So thank you everyone.
You can register right now by clicking on the link in the